Today I'm going to talk to you about motivational interviewing. The information that I'm providing with you has come from 13 different sources, 2 of which are government public health agencies. 9 of those 13 are peer-reviewed research articles. 8 of those 9 articles were published between 2018 and today, 2021. 8 of those 9 articles are specific to motivational interviewing initiated with a patient who is receiving inpatient care. Motivational interviewing is not something done to a person or performed on a person. I want to make it clear that it is a process and a state of mind defined by a specific skill set, done with a person for their benefit, used in attending to your client with the hopes of enabling them to see and acknowledge a need for behavioral change. First, I'm going to talk to you about what motivational interviewing is, what this mindset is, what the skill sets are, how we're approaching behavioral change with a client or patient. Then I'm going to dive into some of the details of some of the articles, the way it's been applied, the theory behind it, and the successes and limitations there. And then I'm going to wrap that all up by identifying some trends that were common through a bunch of different articles, both about specifics about how staff is trained and who should be doing what, and also the huge opportunity here of technology and telehealth in our post-COVID world to make that motivational interviewing that happens briefly on the floor have real impact. There are 4 attitudes which are discussed as being the spirit of motivational interviewing. The first and primary is one that every nurse is going to get, because we're taught this in school over and over again, is that nurse-patient rapport, that we need to be trusted by our patient. And out of that is going to be born this partnership. And we're going to discuss topics that are difficult with our patient as best we can, and it's going to be grounded in their views and their experiences. We are facilitators of their awareness of a situation. We're not telling them what to do. The second piece is evoking, and this is how we come to understand their perspective of the problem they're in, be it an addiction issue, be it a chronic health issue, be it not having enough understanding of how to manage your diabetes. Whatever that issue is, that's sort of a behavioral problem that's manifesting as a health concern to them, we're going to use those open-ended questions we were taught and find out, ask them questions and listen to them about what their current situation is as they understand it. What are the good things about it? What are the bad things about it? What kind of concerns do they have about their health? What's the best possible future outcome they see from where they're currently at? What kind of obstacles are in their way? And to accept all that and work with them, expressing our understanding of that, understanding that we might encourage them to explore potential goals for tackling problems, but ultimately it's their job to brainstorm the possibilities of change and to set those goals and do the follow-through. There's no right way. They are their own person, and we have to acknowledge that and be supportive of them as they struggle in a situation, but trying to be that helpful hand that helps them see a step forward. And of course, compassion, because nobody's in the hospital because they want to be. Hospitalization, either through the ED or inpatient admission, is a unique opportunity. Weinstein et al. Report that almost a quarter of all hospital patients have a measurable substance use disorder. We also know that the risky behaviors that the public health department tracks, smoking, substance use, obesity, poorly managed blood sugar, inactivity, these are the sources of most of the illnesses our patients come in with. So this unique opportunity arises when these patients have an unplanned admission and they're scared, and they will talk to whoever's there about their fears, about what they did to get there. This is an opportunity to initiate motivational interviewing or refer to someone who's expert in motivational interviewing to begin that process of understanding where they're at, having them understand where they're at, and working towards change talk. That is not us telling them what to do or an infomercial telling them what to do. That is them realizing where they are, that they can be somewhere else, and identifying that first step. That's the change talk that is the goal of all motivational interviewing. There are 5 skills used in motivational interviewing. We've already discussed some of the open-ended questions we would use to understand how and why and for how long they've been engaging in whatever behavior it is that is damaging their health, how they feel about the substance or behavior that they're doing, what is good about it, what is bad about it, what do they like, what concerns them, whatever kind of open-ended, non-judgmental questions you can come up with. That seeing them as a person and understanding their situation. We let them know that we understand this through reflective listening and summarizing their situation. The piece we don't want to miss, and this is going to come up later in a study on smokers, is the affirmation. And that is really important. There was a study that showed that a self-affirmation theory had to be dealt with before you could talk about difficult topics. And so similarly, when we are talking with a patient about their risky behavior, we want to acknowledge the good things they do. Whatever that thing we can compliment them on, that they're in some way responsible, that they're some way thoughtful, that they're some way conscientious. Anytime we can label a positive value on something they did, we want to do that. We summarize their experience, we take those values we've labeled, and we help them see their story with a potentially different outcome. They initiate the change talk. They can see potential steps. Then they may choose to take one. I've already talked about some of the various behaviors that motivational interviewing can be applied to. Here are those I've included in this report. I will spend a lot more time on addiction and smoking and diabetes management in depth. I briefly talk about inactivity and weight loss. There are additional studies about using MI in inpatient settings to reduce fall risks. I did not include those here, but they do exist. These values come from the Massachusetts Department of Public Health's last survey, which is for the 2018 to 2019 year. I'm only going to really pay attention to the adults' values for the 18 plus for the purpose of this discussion. And we can see that almost over 17% of the adult population has used an illicit drug in the last month, and almost 4% have used something other than marijuana. We've got a cigarette usage of about over 15%. And I'm going to go way down to the bottom, which is about rehab. They've got some rehab numbers, but I want to focus on those that need it but have not received it. And I'm going to pull the numbers for the illicit drugs, and I'm going to pull the numbers for substance use. When you combine those two values, you have nearly 11% of the adult population in Massachusetts has an addiction issue that is not being treated. Weinstein et al.'s journal article is a very in-depth review that covers a wide variety of addictive substances. They very much promote a team approach that uses a specialist liaison to do the motivational interviewing. But they focus on the nurse being the first point of contact for that referral. And this process, the first 4 squares in this diagram, these are all done at the hospital, as we already know. We acknowledge that the patient has an issue. We order the laboratory information to find out what they're on. We initiate the motivational interviewing. so we can get that readiness and work with the patient to accept the referral you're going to give at their discharge, while you manage that withdrawal they're having and prevent more acute health risks. Weinstein makes a really good point about studies that show that just that intervention with the MI in the hospital has an increased benefit, even if cessation isn't the outcome. There is still a reduction in usage. There is a reduction in readmissions. There's increased provider knowledge. And so those are some of the benefits of doing this, regardless of whether admission to rehab or return after treatment occurs. Although he does for certain things like providing methadone inpatient, it has an 86% return rate after discharge. So those people will continue treatment and stop some of their risky behaviors. Martino et al. Conducted a randomized clinical study to look at the best method for deploying motivational interviewing to address substance abuse in general MEDSurg floors. And they enrolled 38 different providers, doctors, advanced practice nurses, and RNs, and they distributed them evenly among 3 different training groups. All 3 training groups received the same one-day workshop on motivational interviewing provided in accordance with Motivational Interviewing Network of Trainers' recommendations, and additional instruction in CAGE, cut down, annoyed, guilty, eye-opener screening methods, and heaviness of smoking index. In addition to the training given to the providers, 4 clinical liaisons were identified, 3 of which were psychiatrists. The remaining one was a licensed social worker. They received 2 days of skill-building workshops, then 3 post-workshop supervised practice case studies, and monthly follow-up group meetings and supervisions to maintain proficiency. These 4 people are then utilized in the apprenticeship category, being the trainers that work with the clinicians in individual cases, and they become the body of specialists the consult group refers patients to for motivational interviewing. All patients admitted were offered an opportunity to participate in the study. If they chose to, they were screened for 3 things and paid $30 for their time for the screening. The screenings included reasons for exclusion, history of the past 28 days of substance use, and also an administration of a mini international neuropsychiatric inventory. And anyone with a score of 2 or greater was considered to have a significant substance use disorder that practitioners should identify. Of the patients that the survey indicated may have benefited from motivational interviewing for substance use disorder, only 20% received motivational interviewing. Despite the challenges of having to engage the patient in motivational interviewing before their discharge, the clinical liaisons were able to engage over 86% of the referrals that were sent to them. We've all had the pre-contemplation patient, the one that feels calcitrant against accepting a referral to rehab, the 40-year-old alcoholic with a second acute hospitalization near organ failure who refuses even discussing it, the bright young adult who's enjoying themselves far too much to fear what lies ahead. How do you move this person from this place of unreachability towards action? Let's talk specifically about smoking. The Massachusetts Department of Public Health identifies 12% of adults as smokers, 6.9% as vapors, and also has statistics that 55.3% of Massachusetts smokers have stopped smoking for at least 1 full day in the past year in an attempt to quit. That means they are not pre-contemplative. This is data from a study that looked at treatment for smoking and smoking cessation using 3 different models. There's a health education, There's motivational interviewing in the black and brief advice in the blue, which is another model of frequent low pressure kind of prompt. This study used all three of these on a group of patients, looked at two properties. They're defining the term efficacy as the number of patients you could get to cease smoking, and the second term was relative effectiveness, which was a value determined by the number of non-smokers you created and patients you moved forward towards readiness and action, minus those that you demotivated. And this is kind of interesting because health education, specifically in the very early stages, demotivated patients that were already beyond pre-contemplative. The analysis in this study used a Markov chain and ordinary differential equations to assess and evaluate these two attributes and project them out as far as 2 years. The Bommelé study is a smoking cessation study, and they're really on to something. Their background piece explaining the theories that they're employing in their study is far better than anybody else's. And so I'm going to go ahead and just outline those 4 theories that they were trying to implement. So the first one is the self-affirmation theory, which says that people want to believe themselves as good people, and so therefore they become very protective of their integrity and don't want to see themselves acting outside of cultural norms or to their own detriment. This is what I mentioned briefly when we said affirmations are part and part of motivational interviewing, and you can use those affirmations up front before digging into the difficult stuff, and that they show this in their study, that is important. The health belief model says you can predict the likelihood of a person changing behavior if you look at 2 pieces of their perception of a situation. One is their perception of how likely they are to suffer because of a specific illness or the severity of that illness, and balancing that against their perception of the barriers to avoiding the illness, money, dangers, side effects of a vaccination, annoyance, inconvenience of treatment or prevention measures. So those 2 aspects, and we're seeing this play out fully in COVID right now, but you can predict someone's behavior based on their perception of those 2 items. Reasoned action approach states that attitudes drive people's intentions drive their social behavior. And those attitudes related to change, norms, perceived behavioral controls, those are the things that drive their intentions. And lastly, self-efficacy theory. One's belief that they can succeed determines if they're going to actually initiate a plan of action. And lastly, self-efficacy theory says that no one's going to take action unless they believe they can succeed. And there's one last thing that is evident in Bommelé's data that they don't talk about, and that is the foot in the door approach. And that's going to play out, and we're going to talk about that more later, but I just want to say that that's also visible here, but talked about in someone else's study. The Bommelé study is a random controlled trial of 3 online sessions offered to inpatients who were smokers of 5 years or more and who smoked 15 cigarettes or more a day with no history of quitting and no desire to quit. Volunteers were asked to participate on an online research project regarding smoking. They were told there would be 3 online sessions, each about 30 minutes each. They were to be done at discharge, 2 weeks post-discharge, and 2 months post-discharge. The control group watched 3 online videos that had no judgment about smoking, did not actually talk about smoking, but talked about the history of tobacco and its cultivation. After each 30-minute video, the control group participants answered a brief questionnaire that asked questions about how they felt about smoking, how much they smoked, and how they felt about quitting smoking. The intervention group was exposed to a three-prong approach, which incorporated elements of self-affirmation theory, health belief model, reasoned action approach, and self-efficacy theory. Self-affirmation theory infers that hardcore smokers would avoid listening to bad health issues about smoking because it would make them feel badly. So a kindness questionnaire was administered prior to each challenging video session. Additionally, receptivity was increased by using tailoring and motivational interviewing techniques over the course of the 3 sessions. The focus of the first 30-minute video session was to dismantle dysfunctional beliefs about quitting. At the end of this first session, the treatment group answered the same questionnaire as the control group, but also had additional questions focused on their attitudes towards quitting and their fears about quitting. The second session was focused on improving attitudes towards quitting. The third session was a series of videos of former hardcore smokers and how they took on the challenges of quitting and how they dealt with challenges to stay quit. The project's conclusions were that the long-term effects of their intervention were unclear, and they said it seemed to increase receptivity to quitting information in the short term, but that it didn't affect hardcore smokers' self-efficacy or intention to quit. It's reasonable to have soft conclusions when you see a control group that has similar trends to the intervention group, but with a slight delay. This brings me to a concept I came across in Lee et al.'s protocol. They discuss the foot-in-the-door technique, which they attribute to Freeman and Fraser in 1966. As they describe it, they would introduce motivational interviewing by asking for a very easy, attainable health behavior change, thus getting a foot in the door before asking their chronically ill smokers to change the hard behavior. Since Freeman and Fraser's work isn't exactly contemporary, I went to look for a more modern research and application of the foot-in-the-door technique, and I came across a reproduction of the original Freeman and Fraser study, which had confounding results. The team conjectured that the way in which the hard behavior was asked for might change whether or not it was done. So I noted the author and found Gamian-Wilket's follow-up study. Gamian-Wilket's team conducted their test in a canteen and a big university, and their subjects did not know that they were part of a study. They approached them at random and asked them for what was considered the standard task, which was a 15-minute long survey on bath products. And then some of them were approached immediately afterwards for the difficult target behavior, and others were on a delay. And so the difficult target behavior was a request to partake in a 2-hour discussion on bathing products. Additionally, this encounter was done with explanation and without explanation. So there were 3 conditions under which they were asked to do a task, either given a logical explanation, which was ended with, because our company wants to learn about the preferences of our potential clients, or given a placebic, illogical reason that ended with, because our company is conducting market research now, or given no explanation. The control for this was done in a similar setting on campus, where students were approached to and be asked to do only one task, no second task asked, either the short task of a 15-minute survey or the long task, with the various explanation options as well. So these were their findings, and it's not so much a line, although they're connected. The far left column is the logical explanation for the task. The middle column is the placebo irrational explanation for the task, and the far right is no explanation for the task. The dotted lines are the first initial ask, and the solid lines are the difficult target behavior. If we just look at the easy first ask, that simple task asked with a different variety of explanations got different results. So the logical explanation on the far left is grouped in a nice tight grouping. Over 60% of the people complied. The non-significant placebo explanation yielded varied responses, ranging from the control type score of 40 up to something more like the higher one of the logical explanation. When you look at the no explanation provided, they all sort of converge in a very tight grouping right around the control response of students who were just walked up and given a survey. It's easiest to see what's going on with the difficult target behavior if we pull that out separately. And let's first look at the green line. That's our control. Of the people randomly walked up to with no prior experience with the interviewer and asked to do the 2-hour info session, 1 out of 10 agreed to it for whatever reason, regardless of whether it's a logical request, illogical request, or no explanation whatsoever as to why they should do that. That situation improves if first they've done something successful with you and have a relationship with you. If it's a logical explanation as to why they should do this, then you have another 10%, 13% jump on board. If you give them a ridiculous answer, they're like, why should I spend 2 hours? And you have less people, less than the control, will do a follow-up painful activity. And then if you provide no explanation, you get a couple extra people to jump on board. Gamian-Wilket and Dolinsky's paper is titled Mindfulness and Compliance: The Way We Make Request Influences Compliance with the Foot in the Door Strategy. Studies have said that mindlessness on the short term increases compliance. So if you had no delay and you were going to ask, it didn't matter what logic you put to the question. I give you an easy task and you do it, and then I ask you a hard task. You're more likely to do it without having to think about it. The other studies had shown that time reduced this behavior. So this study then is looking at when you have a logical argument, that foot in the door approach becomes more successful to overcome a hardship if you allow some time. The blue line is the result of time to think. This data supports Gamian-Wilket and Dolinsky's theory that the foot in the door approach is enhanced by engaging the mind. The delay allows for mindfulness and enables the strong logical argument to garner higher compliance on a difficult task. According to the Department of Public Health, 7.6% of adults in Massachusetts have diabetes. Another 7.5% are pre-diabetic. Quick math tells us 15.1% of the adults in Massachusetts have blood sugar issues. And we all know uncontrolled blood sugar issues cause cardiovascular disease, neuropathy, nephropathy, and retinopathy, among other things. I came across this really intriguing study done in Israel. Abu-Saad and team did a study looking at type 2 diabetes in Israel's cultural minority. So we're looking at the Arabic population that has an entirely different culture, different foods, linguistically is different, is the socioeconomic disadvantaged portion of the population in Israel. So a number of parallels that could be applied to other disenfranchised populations who have health disparities. In this study, they use motivational interviewing and tutorial software and nutrition databases that are culturally adapted alongside their traditional treatment. So the control arm receives 4 educational sessions scheduled at 3 months, 6 months, 12 months, and 18 months. This is the standard health education given in the dominant language, not the native language of the patient, and that's the control. Those in the treatment arm received 4 face-to-face motivational interviewing sessions in the same timeline and access to a database with educational services and culturally adaptive software support to teach portioning, exchanges, and how to track progress. And this software included a database of foods that were the ethnic norm for this population. Education was the primary outcome monitored for this study. Additionally, A1C, physical activity, dietary intake, and patient satisfaction were measured. But here we see in the treatment group the adaptive computer education versus the standard lifestyle advice, an increase in full comprehension and a decrease in no comprehension, a narrowing of the partial comprehension. We see improved compliance. We see reduced no compliance. And significant here is the fact that the tracking that was enabled by having software that was in your own language with your own foods in the database and at your fingertips was incredible. With the improved compliance and the improved tracking, the patients in the treatment group saw an improved A1C across the board compared to their peers in the traditional education not provided in their native language and not provided with follow-up in their native language. 2 of the studies I've mentioned to date have used technology to enable access to motivational interviewing. So Bommelé's enrollment of inpatients in a smoking research project was a way to extend that inpatient moment of reachability into an intervention afterwards. Abu-Saad and all use that software to bridge the cultural divide and improve tracking. We're going to look at a couple other studies that are specific about how technology can enable better access and retention of patients in treatment. I think this is a critical time to consider this as telehealth is kind of blooming, and there's definitely an inability to reach this population. So we're going to talk about a meta-analysis of telehealth weight loss randomized clinical trials that use motivational interviewing. This study is a comparison of motivational interviewing conducted over telehealth, mobile health, and e-health methods versus conventional in-person coaching, which is shown in this chart as active comparator. This study includes 16 trials that occurred between 2011 and 2018. 12 of the 15 were over the phone, 2 were email, 1 was internet, and the dates of them are from 2011 to 2018. This study refers to Armstrong and all from 2011 as a seminal work in the area of telehealth and motivational interviewing. In this chart, the dark line is the telehealth motivational interviewing. The active comparator is the striped line. That would be your in-person motivational interviewing. And the gray bars are the controls of no treatment, no coaching. Anything with an asterisk was statistically significant. And although this chart does not show that telehealth is better than in-person coaching, it certainly does not say it is not effective. All modes of motivational interviewing delivered showed improved program retention compared to the comparator arm, 80% retention versus 58% retention. Additionally, those studies which measured the level of engagement for the client involved in the motivational interviewing had higher weight loss outcomes. One study concluded that contact time improves outcomes. They characterized engagement as either as high, medium, or low intensity. High intensity was 14 or more sessions per seen months. These programs using this level of intensity had higher weight loss than those with under 14 sessions in the 6 months. Moderate intensity of 2 sessions a month showed some efficacy. Low intensity of once a month or less did not suggest effectiveness. The next study I'm going to discuss with you is one done at a single site feasibility study done at King's College Hospital in the UK, where inpatients were scored for activity levels using a standard screening. Those who scored inactive or moderately inactive received a 30-minute motivational interviewing prior to discharge and with a pre-agreed upon 2-week phone follow-up. The program was 66 effective engaging voluntary patients in a new activity of their preference. 77% of the eligible patients agreed to participate in the program, and 66% of those that participated were able to initiate and work towards an identified activity goal in the first 2 weeks post-discharge. This translates into getting over 50% of all the patients identified as underactive up and moving following an acute event which compromised the patient's health. The resources utilized to achieve this included one full-time physical therapist who attended a 4-day intensive training and worked full-time with identified patients for 30 minutes prior to discharge and followed up by phone 2 weeks after discharge. From a public health point of view, as well as trying to reduce repeat hospitalizations, this is a very attractive project to fund for a multi-site randomized clinical trial. I know I've already mentioned Lee and their protocol. They were the first people to mention the foot in the door approach, but their approach was to find smokers with chronic illnesses in the hospital and enroll them in a digital motivational interviewing dialogue. They would do a 30-minute motivational interviewing as inpatients, talk about health and wellness, and set a very small behavioral modification goal that had nothing to do with smoking. They would engage the patient using WhatsApp or WeChat, some sort of digital platform that is flexible to people's schedules, but also gives the opportunity to have an immediate response. And they were going to use this to move smokers who were pre-contemplational to higher levels of readiness and towards action. It was a very interesting protocol. It was intended to be started in the first quarters of 2020, and we all know what happened then. So this was published as a protocol that had yet to be executed, and as of spring of 2021, there is no follow-up publication yet, but it would be a neat one to look at. We're going to talk for just a moment about issues of training. We're going to start with Martino, which we've already spoken about, and just pick up that last little detail from that study. And when there's another study that brought up some very interesting issues about staffing for motivational interviewing, and I want to just make sure we add those in before we go to closure. What the Martino study failed to address is why 2 to 4 providers for each group were more efficacious in addressing the challenging topic of addiction. We don't know if they had differences in specialty or training, different attitudes towards dependency, perhaps a family history or personal history with substance use disorders, or just different attitudes about failing. For some reason, 15 to 30% of clinicians, regardless of which group they were in, were better suited to this job than their peers. If I were to be planning an intervention program, I would look into studies identifying such traits in successful clinicians. McGill et al. Approached a study to look at using motivational interviewing and cognitive behavioral therapy with diabetic type 2 population for improved control of blood sugar and diet and weight loss. And this is a study that had already been successfully done with diabetes type 1. So everyone was thinking this is going to be so straightforward. So they enrolled 23 different practices in England. They took a bunch of nurses and randomized them between two groups. They sent one of them to training for specific motivational interviewing and specific use of cognitive behavioral therapy. And the results that they had were pretty confounded. The authors had wisely used the same survey and measure of effectiveness of motivational interviewing for both groups. So the issue was identified. Apparently, there were enough nurses in the control group who unknowingly delivered effective motivational interviewing quite intuitively in their nursing practice, while even the trained group had some practitioners who were not effective. This led the authors to question whether randomizing the groups was the correct thing to do, or whether they should have had people who were inclined to receive this training self-identify. So here are some of the takeaways. Motivational interviewing works to change a wide variety of health risk behaviors. The ED and inpatient admissions is a reachable moment, and enough studies have shown for a variety of different behaviors that it's an effective point for initiating a change. Having staff trained to identify appropriately and make that referral, take the action, is an area that needs improvement. Motivational interviewing improves program retention. Pretty much every article noted that that is one of the features for it. And telehealth and e-health, which we will be seeing increase, is an effective means of executing that motivational interviewing. Not everybody delivers the same quality of intervention, and it may be effective to have very specialized, trained staff to respond to referral. It may not be appropriate to assess an intervention program by how many people make it to the finish line. For each and every behavior we've talked about, there would need to be a mortality, morbidity, and cost analysis to determine if the small steps have a benefit. But perhaps the data could support programs which promote benevolence and helping more people get to a better place. Last point. I'm amazed by the illogical but completely social outcomes of the foot in the door approach. The idea that the patient needs time to ruminate on logic and soften the resistance to embrace and act on their autonomy is a beautiful example of collaboration, autonomy, and compassion converging. It's a great place for us to end. And on that, I will leave you to ruminate on my reference list.